Diving and Ear Problems. Practical Advice by Dr. Frans Cronje. Of all the potential problems that affect divers, ear and sinus problems are not only the most common, but most likely to keep divers out of the water, which is the grimmest prognosis of all. This article offers an overview of the most common diving problems related to the ears and offers some practical advice on how to prevent and manage them when they occur. The significant changes in pressure encountered during diving causes large pressure volume shifts, particularly affecting the air spaces in the body. For some, such as in the case of the intestines, the changes are usually insignificant. But for others, such as the ears, sinuses, face mask and lungs, these changes may be hazardous unless deliberate measures are taken by the diver to prevent the problems. Much of diver training is actually focused on teaching divers these measures. Unfortunately, technical issues are not the only consideration. Upper respiratory tract infections, scarring from previous infections, surgery, anatomical abnormalities, all of these may complicate the ability to adjust pressure in the ears and sinuses. In addition, immersion and exposure to cold water may have potentially adverse effects on the ears themselves. Diving-related problems of the ear can fall into two categories, those related to the exposure to water and the exposure to pressure. Water affects the quality of hearing and our ability to localize sound. Immersion also exposes the external ear to water with a risk of maceration, that is, water logging of the skin, and infection. Cold water exposure may cause dizziness due to stimulation of the inner ear, and over time, chronic exposure to cold water, typically less than 20 degrees centigrade, can produce bony outgrowths called exostoses. Pressure, on the other hand, may result in trauma, which we call barotrauma, ear squeeze during descent and ear block during ascent. It may also lead to the absorption of inert gas, usually nitrogen, with a potential risk of developing decompression sickness. Dizziness, and more specifically vertigo, which is the false sense of spinning, may occur during descent due to rupture of the eardrum with cold entry of cold water into the middle ear, as a result of nitrogen narcosis, pressure on the eardrum being transferred to the inner ear by means of what is called alternobaric vertigo, or high-pressure nervous syndrome when divers dive deeper than about 150 meters. As problems of infection and barotrauma are the most common and primarily affect recreational divers, these will be the focus of the rest of this article. Anatomy and physiology. The ear consists of three parts: the external part, which is partly cartilaginous and partly a bony canal lined with skin and is exposed to water during most of diving. The middle ear is an isolated gas space through which sound waves are conducted to the inner ear and which communicates to the outside world via the Eustachian tube. The inner ear, where sound waves and balance stimuli are converted from mechanical vibrations to electrical impulses, and finally the inner ear, where sound waves and balance stimuli are converted into electrical impulses and conducted to the brain. Each portion of the ear has its own unique features and problems, which we'll describe. The external ear. The external ear begins with this visible auricular appendage called the pinna, which contains a little fleshy protective lump called the trachea, which is right in front of the opening of the external ear. This is a telltale spot, and it provides a valuable clue to identify external ear infections because it becomes tender to the touch. The external opening to the ear canal leads upward, backward, and inward towards the eardrum. The skin over the external part of the ear contains modified sweat glands that produce cerumen or ear wax. This wax is a natural barrier to water and infection, and it is removed by continuous soaking during diving. Beyond the outer third of the ear follows an area of skin with no hairs and no wax glands. This smooth skin overlies bone and is very thin, very fragile, and very painful if infected or traumatized. This external ear canal ends at the eardrum, and the eardrum is a pearly white, semi-translucent structure that is as thin as tissue paper, but surprisingly strong. Bony outgrowths or exostoses. Divers and swimmers, especially those who spend a lot of time in cold water, sometimes develop bony outgrowths in the external ear canal. They're called exostoses, and theory has it that cold water irritates or damages the underlying bone, resulting in a subsequent gradual overgrowth of bone. These bony outgrowths are not troublesome as such, but they can eventually impair the natural removal of wax, water and debris from the ear, or they can even lead to a block of the canal, and when that happens, hearing is impaired and surgery may be required. Swimmer's ear, or otitis externa. The most common problem with the external ear, and the second most common problem in divers overall, is otitis externa, and particularly the version called swimmer's ear. It is the result of a combination of factors including loss of protective earwax, waterlogging of the skin, colonization by water-loving bacteria or fungi, and sometimes additional trauma from divers using cotton buds, foreign objects, or even nails to scratch an itchy ear. The most important preventative strategy is not to fiddle with the ears and, for those who get infections regularly, to try and replace the antibacterial effects of natural earwax with an artificial one. There are various traditional preparations that have been used, and they mostly contain vinegar or acetic acid. There's also a combination of acetic acid or aluminum acetate and sodium acetate, which is marketed as Domaboro and is quite effective in preventing ear infections. Once an infection starts, however, a combination of antibiotics and anti-inflammatory medication is usually required on prescription. Earache due to external otitis can be severe, and once the ear canal is swollen shut, it becomes even more difficult to treat. Needless to say, it can ruin a dive trip, so it's better to obtain medical assistance early. Don't delay. Another preventative measure for people struggling with persistent ear infections is the so-called pro-ear mask or its equivalents. This actually cups the ears in a way similar that the face mask cups the face and eyes, and it allows the ears to remain dry. They're equalized when the person exhales into the mask by connecting tubes from the mask to the ear cups. The mask only keeps the ears dry. Equalizing is still required. External ear barotrauma. Pressure damage of the external ear can result when a diver wears earplugs, when they have a tight-fitting hood that traps air under the external ear canal, or when they have impacted earwax. As the volume of gas decreases due to Boyle's law, the eardrum starts to bulge into the canal, and the earplug may be forced even deeper into the canal itself. Further attempts at ear equalizing will make matters worse because it will add to the bulging of the ear canal towards the outside. Fortunately, it is rare for the eardrum to rupture in this way, and treatment of the earache that may arise is fairly simple. So the advice is not to dive with solid earplugs. However, having said that, there is a so-called fenestrated or pierced earplug called Dox Pro plugs that permit pressure equalization while diving and keeps the ear relatively dry. Although no large-scale research has been conducted, an observational study of 1,000 dives by the Sardinian Institute of Underwater and Hyperbaric Medicine in 2005 was very positive. At least 55,000 divers are said to be using these devices regularly, with no reported adverse events. Our limited experience has also been favorable. Some divers seem to find it easier to equalize with these plugs. Middle ear. The middle ear starts at the inner side of the eardrum. It contains 3 miniature bones, the malleus or hammer, incus or anvil, and stapes or stirrup. These form a chain that amplifies sound waves from the eardrum to the inner ear. The middle ear communicates with the outside world via a partially collapsed tube, which is called the Eustachian tube. And the tube allows oxygen to be replaced because the mucous lining continually absorbs oxygen. The tube also permits pressure equilibration during changes in atmospheric pressure while diving or with altitude changes. When a diver equalizes, air is driven from the back of the throat through this tube into the middle ear. Because the space is semi-closed, however, there's a constant tendency to form a vacuum, and the vacuum is broken by yawning, swallowing, or chewing. Most people can sense a change in pressure equivalent to about 30 centimeters of water on the eardrum. However, if the diver descends more than about 3 feet, this increased pressure will collapse the Eustachian tube and then make it impossible to equalize beyond that point, It's similar to trying to blow through a kinked straw. It can't be done. It first needs to be unkinked by ascending. Middle ear barotrauma. Approximately 65% of divers will suffer from this malady at some stage during their diving years. Diving to a depth of as little as 3 to 6 feet or 1 to 2 meters without equalizing will already cause some degree of barotrauma. If equalizing remains unsuccessful, somewhere between 2 and 10 meters or 6 to 33 feet, the eardrum will eventually rupture. Divers who have experienced eardrum rupture describe momentary relief of pain as the tension on the eardrum is relieved, followed by an episode of extreme dizziness as the cold water rushes in and stimulates the inner ear. As the water warms to body temperature, the dizziness settles and divers may believe that the equalizing problems are over. With water now filling the middle ear space, there's no further need or prompt to equalize the affected ear. But there's some deafness upon return to the surface, and usually some severe pain some 2 to 5 hours later due to an inflammatory response to the water. Between minor irritation and perforation of the eardrum, there's a whole spectrum of gradual tearing and bleeding within and behind the eardrum. Such middle ear barotrauma can be treated by a medical professional. Nasal and systemic, that is oral decongestants, are almost always prescribed in an effort to fix or correct and normalize the eustachian tube function, which is the key to a normal middle ear. Return to diving is usually delayed until pain has disappeared, all signs of damage have resolved, any perforations have closed and healed, and the ability to equalize with ease has returned. The inner ear. The inner ear consists of a complex of tubes and nerve endings that offer mechanical electrical interfaces for sound and balance stimuli. It is organized into the cochlea for hearing and the vestibular system for balance. Unless exposed to high levels of noise, the cochlea is usually unaffected by recreational diving. However, there is a risk of barotrauma to the inner ear, which may have permanent consequences. For these reasons, divers are told never to force their ears to equalize. The vestibular system provides signals for orientation. On land, the eyes and joints offer additional sensory input, but underwater, vision and gravity are reduced so that the vestibular system becomes vital for orientation. Accordingly, disorientation, vertigo, and motion sickness are all related to the vestibular system. They fall outside the scope of the article, however. We would like to concentrate on the pressure-related effects on the inner ear and barotrauma in particular. Strenuous or prolonged attempts at middle ear equalizing, particularly when using forceful Valsalva maneuvers, may elevate the pressure inside the skull and inner ear to such an extent that it causes rupture of the inner ear structures themselves. Vertigo that starts during descent is particularly suspicious when accompanied by difficulty equalizing. If vertigo is ongoing and accompanied by any of the following, medical attention is urgent. These are intense ringing in the ears or tinnitus, a persistent sensation of fullness in the ear, deafness, nausea and vomiting, loss of balance, and jerky eye movements, also called nystagmus. Inner ear decompression illness may present in a similar way, but it's quite rare. It usually occurs during or after ascent and is associated with deep and technical dives, usually including the use of helium. Treatment of inner ear barotrauma is bed rest, with head elevation to reduce the pressure in the brain, which, by virtue of a tube connecting it, will increase the pressure in the inner ear. The diver must be evaluated with an audiogram for the cochlea and a so-called electronystagmogram or videonystagmogram for the vestibular system. They should certainly receive a full ENT assessment and neurological evaluation. Symptoms often resolve spontaneously within 2 to 3 days, and surgical measures are reserved for those cases that are persistent or where there is no recovery or even progression of hearing loss and balance disturbances. As a final note, diving is a safe sport that exerts significant pressure on the structures of the ear. With proper care, training and avoidance of discomfort or pain, injury is unlikely or minimal. Without proper attention, permanent deafness may result and surgery may be required for ruptures of the eardrum and inner ear. Diving with a head cold is not advisable, and never force the ears, and equalize early and often.